I only have one slide, so what I'm going to do now is just give you a patient perspective of life before AD. I wasn't a Barts patient before I had an aortic dissection. In some ways I wish I was, having heard what goes on this morning. But I've only got one slide, and it'll be very quick. This is my story, really. I was born at a very early age, in bed with my mum. And, oh, you can't see that, it's probably just as well. It's just a picture of me and my mum and dad. And we've heard a lot about Marfan Syndrome this morning. I have Marfan Syndrome. I inherited it from my dad. And Dad died of an aortic dissection at age 49 due to Marfan Syndrome. He had a lot of problem with his eyes as well. He lost his sight in his 20s due to Marfan Syndrome, because that's one of the things Marfan's does. And he met my mum because she lost her sight not due to Marfan's. And she was sent to a rehabilitation centre for the newly blind. And my dad was working there as a mobility instructor. So they met and fell in love and married, and I was the result. Some of you have heard that story before, I know. So Dad didn't have any cardiological monitoring, no surveillance. This was the 1970s in South Wales. Suddenly had a dissection in the middle of the night, just before Christmas 1976, and was admitted to hospital. And there was not a lot that could be done for him at that point, so he lived a few days and sadly died just before Christmas of his dissection. And my memories of that time are, I was 11, so my memories of that time are kind of a very dark time in my life, I suppose. And I can remember very clearly just after Christmas in this kind of working class steel-working mining town in South Wales, lots of burly men who were my father's friends coming to pay their respects in the week after Christmas and putting their hand on my shoulder as they went out the door and saying, "Well, Gareth, you're the man of the family now," because I was an only child. So that was how this rather studious young boy became a man at Christmas 1976. It was interesting that I didn't see a cardiologist after what happened to Dad, but which was surprising. There was a lot of people saying, well, you've got two blind parents, it's your eyes that you need to worry about. I was told, perhaps you should learn Braille just as a precaution. That was helpful when you were 11 years old. But cardiologically, nobody really, I didn't have annual monitoring. I went to see the GP who said, if ever you get sharp tearing pains in your chest or up and down your back, go to A&E. That was my advice. They also said, you've got this Marfan syndrome thing, and life expectancy for you with Marfan's at the moment, this is in 1976, is 32 plus or minus 16 years, which is quite something to take in when you're 11 years old. So my mindset for the first 50 years of my life was that I was going to die of an aortic dissection at some point before I reached the age of 50. And that's quite a psychological burden. I carried on with life. I'm a fairly bloody-minded individual, to be honest, and so I ignored all of that and thought, no, I'm going to join the Royal Air Force and I'm going to fly airplanes. That's what I'm going to do. That's my life plan. And Marfan's is one of those things that it is a condition you can live with, and you can have a very successful, fulfilled, and enjoyable life. But in my case, once a decade, it kicked me in the teeth with something acute. And you just have to watch out for that. So in 1989, I had a retinal detachment, lost the sight of my right eye, and I had a marvelous retinal surgeon who restored my vision for me at Moorfields Eye Hospital. And in 1998, 2 years later, my lens is dislocated, and we heard earlier on how lens dislocation can be a Marfan's thing and can be a predisposition or an indicator of future dissection. More surgery at Moorfields, and Moorfields did really, really well. They got rid of my thick glasses, they took my lenses out, they put little plastic lenses in my eyes, and they gave me better vision than I'd ever had before in my life. It was brilliant. And then in 2007, I had a thing called an NSTEMI, which is a heart attack, basically. That was a bit of a surprise. Clear angiogram, did the cardiac rehab, thought, right, I'll just go back to work now and get over that. So each time, every 10 years, an acute episode, and in fact my AD was 10 years after that. I'll talk about that later on. But in between times, I think it's important to have the right monitoring. I didn't have the right monitoring. I studied medical physics at university, and my final year project was to make a phonocardiograph. That's a device that listens to heart sounds. So I made my phonocardiograph and I strapped it to my chest, and one day I stood on the treadmill, exercised, and I took the trace to the physiology lecturer who was going to use the device that I'd invented. Well, not invented, built. And he said, "Where did you get this?" I said, "Off my machine." "Yes, I know, but who was the machine attached to?" I said, "Me." He said, "You need to go and see a doctor, Gareth." Because my phonocardiograph showed a mitral valve prolapse, which I didn't know I had. So off I went to the GP and said, "I built a machine, I got this trace off it, I'm told I've got to come and see you." And that represented my first referral to a cardiologist at the age of 21. And from there on, I had annual echo. And of course, echocardiography, "Yes, we're checking your aorta, Mr. Owens, and it's all fine, it's not growing, it's 3.5 centimeters. That went on for 30 years. Until suddenly, I'll tell you about this later, I keeled over and had an aortic dissection of the descending aorta, which had never been looked at. So that was a bit of a failure of monitoring and surveillance, and it was interesting to hear what Kate was saying about the way you use MRI to look at the descending aorta as well. And I know a lot of clinicians now are changing their practice in Marfan's so that they look at the whole aorta, not just the ascending aorta, and that's totally appropriate. So getting the right monitoring is absolutely vital. Don't miss your appointments. If you're not getting your regular monitoring, ask and get referred for it. Being aware as patients of the risk is vitally important. I'm preaching to the converted here, but this is why we run these events, is so that patients are informed and aware. I was lucky enough that when I dissected, I could say to the ambulance man, "I've got Marfan syndrome and I think I'm having an aortic dissection." Okay. And believe me, that shortcuts the A&E journey quite considerably. Okay, so be aware of the risks. I was offered some genetic counselling. When I got engaged, the GP sent me off to a genetic counsellor who talked about the 50% risk of passing on Marfan's to my children. Our view was that it was possible to live a perfectly happy and successful and fulfilled life with Marfan syndrome, so that's a risk that we would take. We have 3 children, and my youngest son, David, has Marfan syndrome, the other 2 are unaffected. Attitude is also important. It was very important to me, thinking as I did, that I might have a limited life expectancy. It was very important to me to say, well, what do I do about that? And I decided, well, if I can't add years to my life, I'm going to add life to my years. And I like to set goals for myself, sometimes quite stretching goals to aspire to. So I wasn't able to join the Royal Air Force. My eyesight was too bad. I had Marfan syndrome. There was no way they were going to take me. So I had to find an alternative career path in IT. But after my NSTEMI and after my eye surgery, I thought, I wonder if I can fly an aeroplane. So I went and got a medical, and sure enough, that was okay. So I took a summer off, and I learned to fly aeroplanes and fulfilled my ambition. And so I was really pleased with that. And it was one in the eye for the people who told me I needed to learn Braille and not think about doing that sort of thing in life. So that was great. And I'm just in the process of negotiating with the CAA as to whether I can get my pilot's license back post-aortic dissection. Set goals, pursue your dreams, go for it. Don't let things like this get in your way. And the second thing that happened was I thought I'd quite fancy going back to academia, really. I was working at the time. So I had an opportunity and I thought, great. So I went to Oxford and I did a master's part-time. And this is my family at my Oxford graduation, which was, again, before AD, but post-MI. 2 things I never really thought I'd achieve in my life. But I think, taking the right attitude, some of you heard me speak about this last year, having the right attitude towards your disease and realizing that these acute episodes are just incidents in a very much longer lifetime, and they're really serious at the time, and we have to really strive to get through them. But having a condition like Marfan syndrome, having an AD is not the end of the world. There are still fantastic things that you can do. That's the kind of pre-AD story for me. One little anecdote. I think one of the speakers mentioned Abraham Lincoln. And I was once having a medical, actually it was a flying medical with a very eminent London doctor who had me lying on the table, and I had an ECG machine strapped to me. "Oh, Marfan Syndrome, Mr. Owens," he said. "Yes, I know about that." He said, "That's what saw Abraham Lincoln off." And I said, "Really?" I said, "Abraham Lincoln may well have had Marfan Syndrome, but I'm pretty sure it was the assassin's bullet that killed him." Silence. So be aware, and you can always have interesting conversations like that with your medical specialists. I wanted to follow up the surgery session that we had before lunch with Professor Wu and Mr. Flora by just telling you very briefly my story of dissection, surgery and recovery. This is a shorter version than I did at Liverpool last year, because some of you heard it before. But it's important to share it with you. 23rd of March 2016 was the date when I was working in the city, and I set off from my London digs, and for some reason, I know not why, I took a selfie. There it is, all bright and breezy, off to work at the bank in Canary Wharf. And at the end of the day, I took another selfie in A&E at the Royal London. So I dissected in a pub in Monument, not a mile from here. Paramedics came, I said, "I've got Marfan Syndrome, I think I'm having an aortic dissection." They said, "Right, Royal London Major Trauma Centre, that's where you're going." Off we went. I got to the Royal London, and lots of people attended to me very quickly. And about 11:30 that Wednesday night, I met this gentleman over here, Sandip Sarkar, who was, I think, the on-call consultant vascular surgeon that night. And Sandip very quickly got me into the CT scan. When I hear about people waiting days for a CT scan, it's hard for me to relate to, because I just remember Sandip at my bedside going into the CT scan, which seemed a matter of yards away from A&E to me at the time. And then people crowding around the screen and saying, "Oh yes, look at that dissection," and then somebody shouting aggressive blood pressure management as I left in my trolley, and everything started happening, and Sandip was really making that stuff happen for me. So that was my dissection experience, and I was very, very fortunate to be so quickly diagnosed. And what I needed was what we were talking about this morning. I needed an expert multidisciplinary team who were going to care for my whole aorta, and that's what I found here at Barts Health NHS Trust. So I told you before that I thought I was going to follow my dad and die of a dissection around about the age of 50. And so the conversation I had with Sandip went like this. He said, "Yes, Gareth, you are having an aortic dissection. The scan shows it." And I said, "This is history repeating itself." I said, "My dad came into hospital in an ambulance with this. He died a few days later." I said, "I hope I've got a few days, haven't I?" And we talked about the fact that the next few days were absolutely critical for me, and that I was very seriously ill, and that my wife and my son should come down from Yorkshire and get with me as soon as they could. And then Sandip drew me this diagram. I think it might have been a day or two after. I can't remember exactly when it was, but Sandip drew me this diagram on a piece of paper, and I've kept it because it's very special. I'm going to get you to sign it later, Sandip. But he said, here's your heart, and here's your aorta, and this is what's happened to you. He said, "Can you see that there's this normal tube here? That's where your blood should be flowing, but your aorta has bulged right out here and tapered all the way down from left subclavian artery, all the way down past your kidneys and into these iliac arteries here. Oh, by the way, you've got a big bulge there. That's an aortic aneurysm. You're dissected down into your iliac arteries. There's a flap here. The blood's going down into the false lumen with a classic double-barreled thing. And you've got a very extensive dissection." He said, "But if you survive and you get a bit more stabilized over the next few days, there are things we can do that we couldn't do when your dad died." He said, "And what I think will happen is you'll go across to Barts, and with the cardiothoracic surgeons, you'll have very major open surgery on your aorta up here to fix that with a graft. And if you survive that and you recover well from it, then you can come back here to the Royal London Hospital, and I will be happy to support you through this operation to fix the abdominal aorta and the iliac arteries." And this is a special diagram for two reasons. After this, We went through the whole MDT process. I had every aortic expert and his dog in Barts Trust opining on my scans, having discussions about what the right thing was to do for me. And what stayed with me is this, that after all that had happened, exactly what Sandip put in this diagram that night is what occurred. 2 operations, one after the other. And that, to me, is a hallmark of excellence. If an expert in a very complex and dangerous situation can tell you how things are going to pan out, then that's a hallmark of excellence. And so that's the first reason that paper is very special to me. It should form part of your annual appraisal, Sandip, it really should. Okay. The second reason is I thought I was dying. I had no basis for expecting a future at all. In fact, the evidence that I had, which was my dad's dissection, suggested that I was dying. And what Sandip did in drawing this diagram and having a 5-minute bedside conversation was to give me hope. And those of you who work in healthcare, never underestimate the power that is yours to give the patient hope. Because that, along any conversation I've had in my life, has so completely turned around my mindset as that conversation. And I thought, if there's hope, I'm going to go for it. I'm going to survive. I'm going to have the surgery. I'm going to live, and I'm going to recover. I didn't think that I'm going to chair Aortic Dissection Awareness UK, but that happened too. So that was a very, very significant moment. For those 2 reasons, it took away a lot of that psychological burden. So off I went. I had, actually, it's probably better to show you this than tell you it. So I don't think Professor Uppel is here, is he? No, he's probably operating still. Is Professor Wu here, or is he gone as well? Professor Wu, would you mind joining me? Is Mr. Flora here? We're gonna reenact my surgery live on stage. That's what we're gonna do. Come on the stage. All right. There we go. This is the entertainment section. Mr. Flora, come and join us on stage. Right, great. Professor Wu, have you seen one of those before? Yeah, okay, you know what it is. Okay, good. So, first operation was here in the Barts Health Centre with Professor Uppel, and it was to implant a Dacron graft from left subclavial to T6. Can we do that? Not left subclavial, T6 is key. Hold it there, yeah, just so that I just can see. Are you happy with the positioning of that for the distal anastomosis? Because the distal anastomosis is the tricky bit, right? Yeah, it's a tricky bit. So just hold that there for me. Thank you. And Paul, it's a year later, Paul got, have you seen one of these? Sorry, it's a bit of a lash up. So if you could, Paul repaired my abdominal aorta and iliac artery, so if you can just, I don't mind, Paul, because you've been there before. Right, just hold it sort of under the kidneys, and you've got 3 ends there and only 2 hands. I think we need Mr. Sarker to assist with the iliacs, don't you? Okay, because Mr. Sarker is an expert in lower limb perfusion, aren't you? Yeah, so don't. Yeah, very good. And David's just going to get a picture for the family album, if you don't mind. So all smile at the camera. And that, ladies and gentlemen, is how an expert multidisciplinary team repairs a complex aortic dissection. Thank you so much. Professor Uppel will be very grateful he didn't have to do that, Professor. Okay. So that was the surgery that I had. This is a picture of me in ICU at Barts after the first surgery. This is a picture after the second surgery. I was quite poorly after the second surgery because I'd lost a lot of blood. But the ICU people at Royal London looked after me really well. And this is a picture of me recovering at our summer buddies garden party in Anne Cotton's house about 6 or 7 weeks after the second surgery. Recovery's tough. It's the hardest thing I've ever done in my life. But one day at a time, slowly, gradually stretching yourself, and you get back to the sort of brilliant outcome you see before you today. Okay. So that was my experience. Main message from this: rapid diagnosis, quick CT scan, get into the hands of an expert multidisciplinary team The research tells us that multidisciplinary teams deliver better outcomes for patients. So the second thing we want as a patient association is to see specialist aortic centres with effective multidisciplinary teams where the surgeons are performing the right volume of these operations and are delivering better outcomes. I feel, having benefited from this approach here at Barts, I almost feel a moral obligation to ensure that all other AD patients in the UK can get access to the same level of care that I was lucky enough to receive here. And we are a long way from that. Some of you know that. And I'm not happy to see people who are still being misdiagnosed. I'm not happy to see the stories of people who don't have genetic referrals, who don't have the right imaging and the right surveillance, who don't have the right surgery, who don't have the right outcomes. And that is what motivates us as a patients association to want to make a difference.